on time. Yes. So I'll be giving a countdown in 10 seconds. We can start then, right? Unnati, are we ready?
Yes, I'm ready.
Okay. Ready? One. Yes. Two. I'll three. And we are like.
Very pleasant evening to all of you. Welcome to our brand new episode of our academic program on obesity management, which is hosted together by Doc Plexus and Center for Metabolic Surgery. Headed by Dr. Raman Goyal, CMS is amongst India's top bariatric surgery center. It comprises a team of surgeons, physicians, dietitians, and psychologists to assist on weight loss surgeries. We have a very special guest with us today to talk about obesity and pregnancy. The name is not unknown to anyone in the medical fraternity, Dr. Kiran Coelho. It's a pleasure to have you here, ma'am. Dr. Kiran Coelho is head of Department of OBGYN at Leelavati Hospital and Research Center, Mumbai since 1996. She is also an honorary consultant of OBGYN in Hinduja Healthcare Surgical and Holy Family Hospital. She is also a member of Managing Committee of IIGS 2021. Prior to this, she was assistant professor at the Tamil Nadu Medical College and BYL Nair Hospital. She is a faculty of CMAS, which is the Center of Excellence in Minimal Access Surgery Training. So she has had visiting observership in robotic surgery from Mayo Clinic, USA in 2019. She has been practicing minimal invasive surgery since 1994 and has trained more than 500 gynecologists in endoscopy. Currently, she's a DNB teacher and has over 40 years of teaching experience. She's been felicitated by the Guinness Book of World Records for being a part of world's largest health talk on breast cancer awareness. It's an honor to have you here, ma'am. I would now request you to please commence your talk.
Thank you so much. I share my screen. Good evening, everyone. It's indeed a pleasure to be part of Dr. Plexus. And as I said, when Dr. Raman Goyal calls, I always come. And today I'll be speaking on a very pertinent topic, obesity and pregnancy. We know that in the 21st century has seen an epidemic of obesity and other lifestyle diseases that are interlinked and have similar metabolic consequences. During the same time span, we have witnessed a parallel remarkable progress in infertility management as well. And as a result, we are seeing more and more obese women getting pregnant. We'll go to the next. So, 1 minute. Yeah, the hospitals I work, Leelavati and Khar Hinduja. And first of all, I just define obesity. It's defined as having a BMI of 30 or greater, a body weight of more than 20% the normal weight for the optimal height of the individual. And the BMI or the body mass index is a useful measure of obesity and is a simple index. So weight for height used to classify underweight, overweight, and obese adults. The BMI is calculated by dividing a person's weight in kilograms by the square of their height in meters, that's the kilograms or meters square. The lowest risk is a BMI of 30 to 34.9. Medium risk is a BMI of 35 to 39.9, and the highest risk is a BMI of 40 or greater. Now in India, we come across both nutritional extremes. Undernutrition is more prevalent in rural areas, whereas obesity is 3 times higher in urban areas. It is believed that in severely undernourished women, as well as in those with extreme degrees of obesity, anovulation and amenorrhea are highly prevalent. It is perhaps nature's way of suspending reproduction in nutritional extremes, as nature finds the state metabolically unsuitable for procreation. However, because of the advances in infertility, such women are also getting pregnant, giving us new challenges. And bariatric surgery has added issues in the management of such pregnant and obese women. Now, in the USA, 2/3 of women of childbearing age group are obese or overweight. The prevalence in UK has also increased from 9 to 10% in the early 1990s to 16 to 19% in the 2000s. And in the Indian subcontinent, the prevalence of overweight or overweight married women, obese or overweight married women in the age group of 15 to 49 years rose from 11 to 15% in the 2005-6 as per National Health Survey 3, and further to a 20.6% as per National Family Health Survey number 4. So we know that the BSI, I just turn off my phone, sorry. As I just said, BMI less than 18, it is the underweight, then of course the average, overweight, and the obese range. Now, how much weight does a person put on during pregnancy? In the first trimester, the total weight gain in a healthy pre-pregnancy state is, I would say the total in a healthy BMI woman, a woman would gain about 11 to 16 kilos. In an overweight BMI pre-pregnancy, then it should be ranging between 7 to 15. And in a patient who's obese during pregnancy, the range should be only 5 to 10 kilos. That is recommended weight gain for an obese patient during pregnancy. Now let's see the weight gain during pregnancy. 25 to 40% of women gain more weight than they should during pregnancy. And this is more so in urban India, because in urban India, pregnant women are very pampered. They are given extra food, so much of ghee, etc., thinking that they would, and they very often eat for two. So weight gain is quite a lot during pregnancy, and this is what we have to, work against. Now, the adipose tissue serves the following functions. It's an energy storehouse, a cushion from trauma, regulation of body heat, and hormone production. But when there is an imbalance, then obesity occurs. Now let's see the effect of obesity on pregnancy. In the antepartum period, that is during the period before the patient delivers, there is a greater chance of spontaneous abortions and recurrent miscarriage, a greater chance of congenital anomalies, stillbirths, preeclampsia, gestational diabetes, and occult type 2 diabetes. So this is a known factor. There are cardiac dysfunctions, there's sleep apnea, proteinuria, non-alcoholic fatty liver disease is seen in obese patients. And this is very important during pregnancy, because during pregnancy, there is a load on the liver already. And these patients are more prone to get liver disorders during pregnancy, which could be fatal. Carpal tunnel syndrome, because of the obesity, pregnancy associated, I think that's pregnancy associated high blood pressure, I'm sorry for that. And post-term pregnancy and also multi-fetal pregnancies are more common in obese women. Now, during labor or intrapartum, these women are more likely to have induction of labor, a cesarean delivery, a failed trial of labor if they were previous cesarean section. They are more prone to get infection of the uterus, endometritis, and if they have C-sections, womb dehiscence, and venous thrombosis, because they are less mobile than would be a non-obese women. Now, in the postpartum and long-term sequel in obese women with pregnancy, they have postpartum weight retention. There's early termination or not at all breastfeeding, postpartum anemia, depression, infection, venous thromboembolism, we see a lot, postpartum hemorrhage, and prolonged hospitalizations. Now, in the fetus of women who have morbid obesity, there are greater chances of congenital anomalies, fetal death, intrauterine fetal death, prematurity, macrosomia or large babies, low 5-minute APGAR scores, neonatal seizures, hypoglycemia, impaired growth, meconium aspiration, greater chance of NICU admission, and studies have shown that there is more than a 2-fold risk from fetal distress as evidenced by low APGAR scores. Now, this study from JAMA says very clearly that the absolute risks for 10,000 pregnancies for body mass categories of 20, 25, and 30, there is a definite increase in fetal death, stillbirth, perinatal death, neonatal death, and infant deaths. Also, there is, in this study shows an increase in the congenital anomalies in obese versus non-obese gravida, where there is an increase in neural tube defects, spina bifida, cardiovascular anomalies, septal anomalies, cleft palate, cleft lip and palate, anorectal atresia, hydrocephaly, and limb reduction anomalies. And this is well documented. Now, in the child, when they grow up, they may have a metabolic syndrome, they may have childhood obesity, asthma, altered behavior, and studies have shown a 4-fold increased lifetime risk of overweight and obesity, and a lifelong elevated risk for diabetes, hypertension, cardiovascular disease, cancer, and early death. These are children of maternally obese women. Now, there is as I said earlier, there's a greater risk of induction of labor because they don't go into labor frequently because the head is high and not well applied to the cervix. So there's an increased risk of postpartum pregnancy, and subsequently there's an increased risk of labor induction. And it is estimated to be at least 1.7 to 2.2 fold. There's an increased risk of operative delivery. And this is the really important thing, because with most of these women, instrumental delivery like forceps and vacuum increased by 18% if women with a BMI of 35.5 to 40, increased 34% in a BMI more than 40. The cesarean delivery is more common, 47.4% compared to control patients of 20.7%. As for this study, we set all, but this was in 2004. And more recent studies show that in obesity, especially when the BMI is more than 40, 120 to 100% of them do have to have an elective cesarean section. The rate of normal delivery following cesarean section are also very much reduced. Now, the operative risks during cesarean section for an obese women are definitely increased operative time found in the morbidly obese. The increase in operation theater time, there's a linear increase in skin incision, uterus time to the delivery of the baby, that increases, and therefore there's a decline in umbilical artery pH. So it takes a longer time to take out the babies in these patients. There's inaccurate or difficulty in pressure monitoring. The anesthetist is always alarmed when we have a very obese patient because they find it difficult in pressure monitoring. There's reduced functional residual capacity. There's sleep apnea syndrome, increase in reflux, aortic cable compression, and poor pulmonary perfusion. There are difficulties with regional anesthesia. When you give a spinal anesthesia, the veins are difficult, unable to find the lumbar spine because of curvature. There's impalpable iliac crest. So all their various parameters by which they find the spine and to put in the spinal needle are all altered because of extreme obesity and impalpable vertebral spines. All that leads to difficulty with spinal anesthesia. And with general anesthesia, there's rapid desaturation on induction. There's risk of regurgitation, potential difficult intubation, potential difficult ventilation, and a difficult tracheostomy. Now, let's see the management during pregnancy. There are extra needs for these women when they come in for both for their antenatal period and also for their delivery. We need larger birthing beds. The average birthing bed for us in India are very narrow. So we need these large size birthing beds, large chairs, wheelchairs. Blood pressure cuffs will never work for these obese women. So we have to have special blood pressure cuffs, motorized lifts, operating table, and long instruments for these patients. Now let's see, prevention is always better than care. So then the cure. So let us see how do we develop these preconceptional care and advice. Must have a preconception screening, diabetes mellitus. If they have diabetes mellitus, optimize blood sugar, look for thyroid diseases and treat them. The TSH should be less than equal to or less than 2.5 when the woman embarks on pregnancy. Otherwise, she will be, because of the stress of pregnancy, she will get hypothyroidism later on as well. Vaccinations, of course, we give rubella, varicella, and always put the patient on prenatal folic acid to prevent neural tube defects, which are anyway increased in obese women. Now let us see how we will see this patient through the first trimester or the first 3 months of pregnancy. We have to do baseline assessments, like, of course, maternal weight and the body BMI is calculated, blood pressure using an appropriately sized cuff, early ultrasound, not only to know the gestational age, because very often we cannot palpate and find out what is the gestational age. So an early ultrasound is a dating ultrasound, not only for gestational age, but also to rule out any multifetal twins or triplets, etc., which are more common in obese women. Medication review, and if the patient is diabetic and on oral hyperglycemic drugs, we should discontinue it very often in favor of insulin therapy. Diabetes screening is a must in first trimester, and of course, quantitative urine protein, kidney function tests, platelet count, liver function tests, because many of them have NASH, and baseline evaluation for preeclampsia or pregnancy-induced hypertension. Obesity, we know, is a known risk for non-alcoholic fatty liver disease. And if the patient has had bariatric surgery, we have to evaluate for and treat nutritional deficiencies. Now, counseling. In the first trimester itself, we counsel for the pregnancy risks associated with obesity. We give them a proper diet in consultation with the dietitian. We explain how much the gestational weight gain should be, and of course, good counseling on exercise, where definitely a prenatal Lamaze consultant would be consulted to give appropriate exercise. We have to encourage weight loss by 5 to 7% in the first trimester and promote lifestyle modifications like a hypocaloric diet, exercise program, and medication. Failure to lose 10% of weight despite lifestyle and diet control will be ominous for such patients later on. Then in the first trimester, most importantly, even though we do fetal aneuploidy screening for all women today, it's especially important in the obese mother. It should be the same as for general. The obese women are not at increased risk for fetal aneuploidy. They are more at risk for neural tube defects. Obesity can affect the screening test performance. And if we do what we call an NIPT, or a non-invasive prenatal testing, then the cell-free fetal DNA screening is more likely to result in test failure. So therefore, serum-based screening tests are adjusted for maternal weight, and so that the obesity does not affect the test performance. An accurate nuchal translucency measurement that we do at 11 to 13 weeks will be more difficult to obtain because of the abdominal fat. So very often we have to use a transvaginal probe even at this late stage of pregnancy, which normally we would do transabdominal, but we'd have to use a transvaginal probe to get a more accurate NT measurement. And diagnostic procedures like amniocentesis, Corion-Willis sampling, etc., more challenging technically. And we have to use a low frequency trans and vaginal probe in the umbilicus and all sorts of permutations and commutations to get a proper testing for screening in the first trimester. And of course, the first trimester is also a period of time where we would like to do reference. If there's an underlying cardiopulmonary disease is suspected, then cardiology or pulmonology reference should be considered. Consider sending to a diabetologist, a sleep specialist if there are symptoms, and of course to the dietitian. Most important reference. Now we come to the second trimester, that is from 20 weeks up to 28 weeks. This is the time where we would like to start low dose aspirin because these are the women who are very prone to get deep vein thrombosis, and we have to protect them against that. Low dose aspirin till 32 weeks of pregnancy is definitely advised. And we know that the BMI of more than 30 kg per m², or BMI of more than 30 is a moderate risk for preeclampsia. And so they should be on a salt-restricted diet from now. And therefore, they will definitely benefit from a salt-restricted diet as well as low-dose aspirin. Other moderate risk factors are if the patient is having a baby for the first time, nulliparity, a family history of preeclampsia in mother or sister, races, of course, increased maternal age, and personal factors, like if there was a low birth weight or small for gestational age, previous adverse pregnancy outcome, and a more than 10-year pregnancy interval. Very often a woman would have a baby at 24 and then she would wait for 36 for her next baby. By that time, she has become obese. So there is an adverse pregnancy outcome if the interval between births is more than 10 years. Now, the fetal ultrasound surveys, very important at this point of time, is a 3D anomaly scan, which we do between 18 to 24 weeks. Now, due to the limitations of ultrasound with increasing degrees of obesity, a concomitant use of maternal serum alpha-fetoprotein to screen for neural tube defects and other relevant congenital defects are very important. So not only will we do this thing, we will also do the quadruple marker test. Maternal obesity per se is not an indication for fetal echocardiography, but usually as a routine, we would do it at 24 weeks, because very often at 20 weeks, the fetal cardiac abnormalities don't show up. They show up after 22 weeks at around 24 weeks. Unless, of course, the ultrasound was not, and usually it is not optimal. So I would like to do a fetal echocardiography. Now, screening for gestational diabetes is ideally recommended between 20 or 24 to, we'd like to do it at 20 weeks, 20 to 28 weeks of gestation, where we do a 75 grams glucose test with read five values, so that we have a proper screening for gestational diabetes. Then assessment of fetal growth. Clinical assessment in these women are a little more difficult and challenging because of the maternal obesity. So ultrasound assessment is better. And although the frequency of fetal demise appears to be increased in pregnancies of obese women, the value of antenatal fetal surveillance with non-stress test biophysical profile scoring in this has not been studied in many studies. But I think after the age of 36 weeks, we'll come to it in the last trimester, but after 36 weeks of gestation, NSTs and biophysical profile scoring should be done every third day, because we know that in obese women, sudden infant death happens after the age of 38 weeks. Now we'll come to labor and delivery. So monitoring of the patient in the last trimester, of course, very important. After 36 weeks of gestation, we do NST, biophysical profile more frequently, and we would like to induce these patients after 38 or 39 completed weeks. Don't let them go beyond the due date. Now, in the labor and delivery, equipment and instruments would change when you have a very obese patient. We have to ensure that the labor and delivery unit has adequate large gowns. You know, very often what happens, these patients are very, very embarrassed when they come to the labor room and they find that nothing fits them. So we must have, once we have an obese patient in our labor room, we should provide for adequate gowns, beds, operating room table, to care for these women and not embarrass them. Fetal monitoring, of course, is completely done throughout labor in a continuous fetal monitoring. Scalp electrodes we don't use so much in India. Anesthesia consultation is a must, because very often we would ask them to either have an epidural, or if they land up in C-section, the anesthetist should see them, evaluate them prior to labor or in early labor, because of their higher risks of anesthetic complications. And for patients planning a vaginal birth, early placement of epidural catheter may obviate the need for general anesthesia if an emergency C-section is required. And I do this very often. Call them when the patient is, say, 2 to 3 centimeters dilated, put in an epidural catheter and keep it in place. If they have a normal delivery, well and good, but otherwise they are already, we are prepared for an emergency cesarean section. Timing and route of delivery is also important. Delivery by the estimated due date has been recommended, but usually we do after 38 weeks, we would like to induce them, because the complications from continuing fetal growth are much more in obese women than, and there are several studies which I'm not quoting, but there are very much more in obese women after 38 weeks of gestation. In a cesarean delivery, since most of these women do have cesarean deliveries, there is very important operative and perioperative care which is required. Of course, we've already spoken about the anesthesia consultation, and they must develop an anesthetic plan that addresses availability of proper equipment for blood pressure monitoring, venous access, influence of comorbid conditions like sleep apnea should be considered for these patients, and an increased risk for hypoxemia, hypercapnia, and sudden death. Now, in spinal, epidural or spinal anesthesia is definitely indicated. The technical difficulties, of course, are body habitus and loss of landmarks. In the epidural in the obese has greater analgesic failure. So early epidural catheter placement is always necessary. There may be extreme hypotension and prolonged fetal heart deceleration soon after an epidural. This is something that we should always be prepared for. And spinal anesthesia in obese significantly impairs respiratory function for up to 2 hours after the procedure, which is what we have to be prepared for also. General anesthesia is not contraindicated, but there are certain considerations which have to be given. One is difficulties in endocranial intubation. So you must have fiber optic equipment available for intubation. There should be adequate pre-oxygenation and proper patient positioning. Now, of course, thromboprophylaxis, one of the most important things that we have to do when we do C-sections in obese women, must use a pneumatic compression device at the time of cesarean delivery. And for obese women, there's an additional risk factor, venous thrombosis. So we must use both pharmacological and mechanical prophylaxis for these women. So we always give low molecular weight dextran for these women. Antibiotic prophylaxis, of course, very important because of so much of fat. They are going to have infection. Preoperative antibiotic prophylaxis for all women and those who are undergoing cesarean section. We would like to step up to a broad spectrum antibiotic should be given as per maternal weight. Now, in the operative procedure, when we do a C-section, the type of incision is very important because these women have a huge panniculus. Some of the panniculus is so big that it covers almost the knee, as Dr. Aman well will know, that the panniculus is so large that the panniculus of this thing comes even up to the patient's knee. So then how do we give the incision? We can't give a vertical incision because there's a higher rate of wound complication, infection, stoma, hematoma, wound evisceration, and facial dehiscence. We give it supra. Suppose there's a large panniculus, but if we can lift the panniculus upwards favorably, then we can take the panniculus, have two assistants hold the panniculus upwards, and then give a suprapubic incision and get away very nicely with a fan and steel incision. If the pannus can be adequately retracted cephalad, then that is the best option. But sometimes the panniculus is so large that we cannot bring it cephalad. Then in that case, we have to give a supraumbilical incision. And so the women who are more than 170, they are less than 170 kilo, we can manage with a fan and steel, but with those very morbidly obese women who are more than 170 kilos, then a transverse supraumbilical incision is suggested, which displaces the pannus, the caudally, and really we can get to. I have done one case, Dr. Aman, of a woman who was 220 kilos, and I had to, the panniculus was so large, I went supraumbilically, but believe me, it was easy. So that is how we plan our incision. Then while making the incision, you have to pay attention to the distorted landmarks in obese women. The umbilicus is often anatomically directly over the lower uterine segment. So that's why the panniculus has to be lifted up. And then the facial closure also, you have to be very careful in giving a very good double breasting Smith-Bloth's closure for the rectus sheath, and the sutures on the abdominal wall should be always interrupted to allow for enough of the serosal material then to be absorbed. One should not close with a continuous suture, so that there should not be a seroma below our suture line. And that these are various subcutaneous closure should be done, And you should avoid placing subcutaneous drains. So close the subcutaneous tissue very well. If it's more than 2 centimeters, don't place a drain, because those drains sometimes cause infection rather than reduce infection. But an interrupted stitch, if you do, even if there's a seroma and you give a tight bandage, then you won't have a subcutaneous collection. And sew close with staples rather than stitches, because they give a firmer wound closure. Now let us come to the postpartum period. This again is a very, very important period in a very obese pregnant woman. You have to prevent venous thromboembolism. And for all women, we give mechanical thromboprophylaxis in the form of your cuff for the both the legs, and then you give ask the patient to give thromboprophylaxis in the form of low molecular weight heparin, which is given even before the labor, 6 to 8 hours, and continued for 3 days after the delivery, and allow the patient not to be immobile. Severe ability, the immobility is so much, so your patient has to be mobilized very fast, and as soon as the patient has you have to protect against infection, as even in emergency cesarean section, and continue the prophylaxis until the woman is fully ambulated. Low molecular weight heparin for the treatment, prevention and treatment of venous thromboembolism instead of unfractionated heparin. That of course goes without saying. And you start 6 to 8 hours, 12 hours post-operatively. Start pre-operatively and continue post-operatively for 6 to 12 hours as well. Then maintain a strict prevention of SSI. Of course, the risk is in C-section is 18.4%. Maintain a strict glycemic control in diabetes mellitus. Give good preoperative antibiotics, intraoperative as well as post-operative. Higher dose of preoperative IV antibiotic prophylaxis. Hair remover for, rather than shaving for hair removal in preoperative, it is better to use clippers, because sometimes the shaving blade will cause infection of the skin. Very, very important. And of course, a good skin prep before surgery. Alcoholic hand rub for preoperative antisepsis is more effective than conventional surgical scrub. And close the skin with subcuticular sutures and also staples. Breastfeeding should be done immediately. Promote breastfeeding, which will promote further weight gain. Each time the woman breastfeeds a baby, it's like walking about 1,000 steps. Now, post-bariatric surgery, I think Dr. Raman Goel will definitely have a long talk on that. It's a recent challenge in our management. The pregnancy should be avoided for 12 to 18 months after bariatric surgery. And post-bariatric surgery, several complications may occur during pregnancy: persistent vomiting, GI bleeding, anemia, etc., etc. I think adolescents undergoing bariatric surgery need special counseling. Pregnancy rates after bariatric surgery are twice the rates in the general population, so they have to be given adequate contraceptive counseling, and alternative tests for diabetes. Gestational diabetes should be considered with those with malabsorptive type of surgery. Intravenous glucose challenge test may be necessary. Evaluation of micronutrient deficiencies, especially in the first trimester. Slow or delayed release preparations are to be avoided, because then they won't work, because they have a very small stomach. Post-bariatric surgery, pregnancies and delivery should be under the combined care or by the bariatric surgeon, physician, and expert obstetrician in a higher center. This is the most important point. And of course, cesarean delivery. And Dr. Raman Goel will speak in great detail regarding this. So in conclusion, obesity in pregnancy poses greater challenges both to the mother and the baby. Therefore, all hands should be on deck to prevent this disorder and the potential sequelae associated with this condition. And I thank you all for a very patient hearing. Thank you.
Thank you so much, Dr. Kiran. That was truly a very, very insightful presentation. I think no one could have explained it better.
Thank you.
And I would now request Dr. Raman to please share his inputs on the same.
So I think, Dr. Coelho, that was so elaborate, and I have heard so many talks on obesity and pregnancy. this is probably the best of them.
Thank you
Because
so
you have not only covered the obesity part, you have also covered how to manage them in an obstetric setup. And a great learning for me where to place an incision. Obviously, I'm not going to do a cesarean,
Yeah.
but to realize that, if someone has to take an incision for pelvic approach in a morbidly obese person, then umbilicus, supraumbilical area also you can reach the pelvis very easily. So I think great inputs, and I'm sure this will be beneficial to all the family physicians and obstetricians also, because for family physicians, it's a great learning to explain to their patients how to be managed after during pregnancy or after delivery. I have two questions for you, if you don't
Sure.
mind.
Yeah.
So one is, though we work together in our institution where we manage bariatric patients, so you have infrastructure, but what about the infrastructure? Because we are seeing increasing number of young women coming with obesity and severe obesity. So when they are coming for labor, do the hospitals have infrastructure in the labor room for managing such women now?
Yeah, now most of tertiary care centers, Dr. Raman Goyal, like where I work, Leelavati, and all these, when we know in advance that we are getting obese patients, yes, we do have a separate set of BP cuffs. We have a big bed which we have specially ordered, both in Hinduja as well as in Leelavati, the birthing bed for a large woman. Then we have special set of clothes, etc. Because that, it's very embarrassing. You have them on the gowns which is open and their whole back is open, so they're very sensitive, first of all, as you know. So we have to give them that extra protection and care. So all these instruments that I said, big hospitals may be aware, but small nursing homes is always a challenge. So I would request everyone, if you have a morbidly obese pregnant woman, should always be in an institutional delivery, not in nursing homes.
I completely agree.
Yeah.
Because this is a major issue happening.
Right.
But a lot of them are in different cities where you don't have the kind of tertiary care centers. And as we see that there are women who are coming for gallbladder surgeries who are 110 kg, 120 kg.
Right.
And when they're going for pregnancy and delivery, it will be a challenge for the hospitals. Okay,
Absolutely.
thank you so much. The second question is about the thromboprophylaxis. You have been very elaborate on this. I just wanted to know. So are you not concerned about when you give these low molecular weight heparin? Are you concerned about the bleeding postpartum hemorrhage in these patients?
Not with low molecular weight heparin. In fact, many of my patients who have got during pregnancy, many of the women who have antiphospholipid syndrome, etc., and many IVF. I do a lot of patients who deliver after IVF. They are on LMWH throughout their pregnancy. Then we stop it just prior to, say, I would say 37 weeks we stop. But we can start immediately postpartum, because it's not pure heparin that we give. LMWH does not increase the risk. So
no, I
in fact,
agree. It
doesn't increase the risk. And if you have a postpartum pulmonary embolism, it is fatal for the woman. I think everyone knows about this Penduska's case, in a case where a doctor couple, Paluskar or something, I think it is in a district in Maharashtra, where they delivered a patient. She was an obese woman, and they went for a conference, and in their absence, I don't think the locum was there, and the patient came back with breathlessness, and on the phone they prescribed something, and the patient died of pulmonary embolism. And now they are in court. They are in jail. Actually, they were jailed. They're out on bail only because there was negligence in the fact that telephonic advice was given and no doctor had seen. So it is a warning to everybody that if we are not there, we keep a locum. Yeah. And we should be prepared that within 48 hours, if a patient comes with breathlessness, think thromboembolism.
Yeah, I completely agree. I raised this point just to highlight it, because in bariatric patients, we routinely give them low molecular weight heparin and the pumps and the stocking and everything. And in a large number of patients, we continue it for a week after discharge. And in some patients who are high risk, we even continue it for a month. So the idea is to somehow ensure that there are no deaths and no major complications. So I completely agree with your statement. Thank you so much. Dr. Unnati, do you have any questions for ma'am?
I do have questions from the audience, doctor. In fact, before the session started, only the questions kept coming.
Okay.
So I have my first question is, doctor, is there a BMI chart to follow an optimal gestational weight gain, or how should one monitor her weight during pregnancy?
No, I gave you a chart. There is a very nice chart that we have, that if you are undernourished, how much weight you should gain. If you are within which BMI type 1, 2, and 3, how much should be the weight gain. So that weight gain is definitely less than what one would normally put on, because usually in the first trimester there is weight loss. Then in the second trimester, up to 20 weeks, there is weight is static. Then after 20 weeks, it's half kilo per week up to the 37th week. So that will be 7 to 11 kilos. That is a normal pregnancy. But if the patient is obese, then the weight gain should be less. And that is why every morbidly obese pregnant woman has to be referred to a dietitian. It should be the dietitian and the nutrition expert plus lifestyle coach, in the sense, we have these Lamaze classes, we have prenatal exercises. So these two go hand in hand. So so we have to monitor that they don't put on too much of weight. And there are
Thank you for that
available.
answer.
And there are charts available. Yeah.
Of course. And you did show that in your presentation. So
Yeah.
I have a question which I know you have answered, but just to reiterate it for the audience. So what are the life-threatening complications associated with pregnancy in obese mothers? This is a question by Dr. Yogesh Yadav.
Yes, of course. Life-threatening is, of course, greater increase of pregnancy-induced hypertension, which will become so severe that even with treatment, you might have to terminate the pregnancy early. You might have, and they are more prone to get full-blown eclampsia, fulminating preeclampsia, eclampsia, and deaths. So that is one. The second, of course, is deep vein thrombosis, which is really the most life-threatening one. And then third is if the patient has to have a cesarean section, and if this anesthetist can't get a spinal or epidural, which they very often can't, and they give a general anesthesia, then sudden death because of pulmonary embolism also, but also pulmonary edema is very common. So these are really life-threatening.
That's all from the audience. I would again like to express my sincere gratitude to you from all our viewers and from the entire Doc Plexus team. I know we all know how busy your routine is and that the kind of patience you have every day. Thank you for still taking out the time and doing this, Dr. Kiran. We look forward to hear from you again.
My pleasure, Unnati. Thank you.
Over to you, Dr. Raman. Would you like to start your session now?
Yep. So first of all, let me thank Dr. Coelho once again for joining here and giving her inputs about obesity and pregnancy. And I'll be talking today on how the bariatric surgery affects pregnancy. Some of the issues have already been discussed, but it's a very important concern. Every woman in reproductive age group who comes to us for a bariatric surgery, she and her family are always asking this question routinely, that what about the impact on her possibility of conceiving, what will happen during pregnancy, whether fetus will get enough nutrition, what will happen to the child thereafter. So I think this is one of the most important questions that we are asked to answer. And it's so important that we work together with the obstetricians like Dr. Coelho and other senior people to understand how obesity and how weight loss after bariatric surgery impacts pregnancy and delivery. So I'll briefly share my presentation, and then we'll be happy to answer a few questions together. So greetings from our Center for Metabolic Surgery. I operate at Wockhardt Hospital and PD Hinduja Hospital at Khar and Zen in Chembur. And today I'm going to talk about bariatric surgery and pregnancy. Now, we all know that obesity affects a person in various ways. There are over 200 comorbidities which are now recognized to be promoted by obesity, and they are the main reason why obesity is now considered a mother of most of the diseases. Just one or two slides on how obesity affects IVF. She has already spoken about it, but there are many studies which shows that in IVF patients who are going for IVF, in women with obesity, there are decreased chances of pregnancy and live birth. So the outcomes of IVF are also determined by the BMI of the woman, and it's very important to realize it at an early stage if IVF is not successful. Just to show you this lady who was 39-year-old when she came, was referred to us by an IVF center from Delhi, where she has undergone 6 or 7 attempts and she could not conceive. And we were also very skeptical to offer a bariatric surgery because she was very emotional and wanted a pregnancy desperately. And we did a bariatric surgery, and in about 1 year's time after bariatric surgery, in her first attempt of IVF, she conceived and delivered a healthy baby through cesarean. And I remember her because she called me from the operating room. She said, I made first call to my husband and second call is to you because of the bariatric surgery. I've been able to have a child, which was a dream. So it was around when she was about 42-year-old and she delivered a baby. Now, how does bariatric surgery what role it plays in terms of metabolic syndrome? We know that metabolic syndrome it makes the pregnancy a high-risk pregnancy because of various reasons, and Dr. Coelho has very nicely explained all that: increasing blood pressure, eclampsia, diabetes, growth disorders, higher rates of cesarean, higher maternal mortality. And we know that the mother's health determines the child's health in future, not only as a child, even as an adult. So there is an increased risk of metabolic disease in the child if mother is obese or severely obese. Now, there is a study which has been done in women who have delivered before bariatric surgery and who have also delivered after bariatric surgery. And they have analyzed the pregnancies of these 288 women. So there were, let's say, about 140 women who had pregnancy before bariatric surgery and after bariatric surgery. And they have shown that there is a significant improvement in hypertension and diabetes. There is a decreased cesarean rate. More women could deliver normally after bariatric surgery. There was decreased length of labor and was decreased neonatal birth weight, because in morbidly obese women, the fetal weight is high, and that becomes much healthier after bariatric surgery. Now, a major question remains, because many women like this lady whom I shown, they come late to us when they are more than 35-year-old, and they want to have a quick pregnancy after weight loss. And so we always encourage them to wait for at least 1 year so that they should not get pregnant during the period of rapid weight loss and metabolic changes which are happening after bariatric surgery. And this study shows that there were 104 pregnancies in less than 1 year. So if you see, the mean was about 7 months of bariatric surgery compared to another 385 pregnancies which happened after 1 year of surgery, bariatric surgery. They found there was no difference in maternal complications, fetal outcomes, or delivery complications. This is our experience also, but this is not to justify early pregnancies. So what happens is that there are many women who are sort of not having periods for a few months or years before they get a bariatric surgery done. And after bariatric surgery, due to rapid weight loss, their fertility improves. And if they are not following a contraceptive measures, they are likely to get pregnant on second, third, or fourth month, or even, and then it becomes extremely difficult because it's a precious pregnancy, maybe after 15 years of marriage, to tell the woman to abort. So some of them, they hide the pregnancy from the bariatric surgeon, and they continue with the pregnancy. And then we find that this kind of outcomes are there. But universally, it is advisable that women should wait for about 8 months to 1 year after a bariatric surgery. A word of caution, which was already said by Dr. Coelho, is that we must, so if a woman is planning a pregnancy after bariatric surgery, we must do a complete nutritional assessment in terms of vitamins, minerals, and other nutritional areas, especially folic acid levels. And folic acid is not only for neural defect, but also folic acid is an indicator of whether the patient is adequately taking vitamins and minerals. So this should always be done. So if a woman comes back to us after bariatric surgery after 1 year and says, I want to plan a pregnancy, we always get this done to make sure that the pregnancy and the baby is healthy. And this I have already said, there are unexpected spontaneous pregnancies immediately after surgery. And it's important that contraception should be discussed with them. Many of them laugh at us that we are not able to conceive and you are telling us to use contraceptive. But I think it's very important that we talk seriously about this and emphasize that terminating a precious pregnancy will be more painful than avoiding it for 8 to 9 months. Now, as far as delivery is concerned, I think she has discussed in detail. But deliveries, the incidence of diabetes and cesarean deliveries were drastically decreased after bariatric surgery. These are the studies which have shown. And bariatric surgery did not increase rates of postpartum hemorrhage, infection, or fetal demise. So bariatric surgery does not cause the kind of complication that people discuss, but it definitely improves the possibility of a normal delivery. Now, as far as impact on child's health is concerned, it has been seen that, as I mentioned, it's not about the child's health, that adult obesity was approximately less, 50% less, if the woman has already lost weight before her pregnancy. So those who are delivered after they have lost weight, they are less likely to have a person as a child who will be obese. So to conclude, this is the position statement of American Society of Bariatric Surgery, endorsed by American College of Obstetrics and Gynecology, which says that obesity associated with delay in conception, it also leads to the male infertility in terms of reduced sperm counts and motility. And weight loss can improve PCOS and insulin-resistant related infertility. There is lower probability of live birth and after IVF in obese, and bariatric surgery is effective in achieving significant and sustained weight loss and thus to improve fertility. Pregnancy is not recommended during the rapid weight loss phase after bariatric surgery, that is the first year. And counseling and follow-up regarding contraception during this period is important. So what is practiced is, or what is recommended is what should be practiced, and that helps in having a safe pregnancy and delivery. Friends, it's important to realize bariatric surgery is the only accepted treatment of obesity which is taken care by the insurance. Now, right from 2013, central government pays for all the bariatric surgeries across the country for their employees and their dependent. Most of the large corporates had been paying for bariatric surgery for last few years. And now from October 2020, all insurance companies are paying for bariatric surgery on a cashless basis. So now after COVID second wave, almost 80% of our patients are being operated on a cashless basis, and they get the surgery done. And then obviously for those who can't afford and have no insurance, then there are financing options. Just to show you, bariatric surgery requires a very good quality operating room facility. We have the same kind of facility. This is Wockhardt Hospital Operation Theatre. We have equally well-equipped operating room at Hinduja Khar as well. And this is the place where you can reach out to us, and we'll be very happy to share to answer any of your questions. So thank you so much for your patient listening. Dr. Unnati, I'll be very happy to answer any questions from you or Dr. Coelho, if you want to go ahead and, yeah, thank you so much.
Yeah, a lovely talk as always, Dr. Raman. I had one question. Do you send them to a gynecologist for contraception? Your patients?
Yeah. So generally, what happens is we tell them to meet their own gynecologist.
Right.
These patients have been with their gynecologist for decades, let's say,
Yeah.
because they've been trying to.
No, I didn't mean that way. Yes, they have to go to their gynecologist, but in these patients, contraception is also a problem, because you can't give them oral contraceptive drugs because they are already obese, and that will increase, and they already have a metabolic syndrome, so again that will increase. Then you put in a copper T or a copper Magilo, that for a young girl you can't do that, and barrier contraception is the only method, and that is not very well liked by the couple. So that's why many of the patients, they conceive immediately.
I think that's very good, because we never thought it this way.
Yeah.
We always tell them that, every woman and the husband knows about contraception, but I think this puts everything in perspective.
Yeah, contraception very difficult in these patients.
Absolutely.
The husband should agree to use a condom, otherwise, and unfortunately in our country we don't have the diaphragm. Others, diaphragm was very good. Then the control is with the woman. So then it becomes very difficult for them. So contraception is a big issue.
Excellent. I mean, I learned something very important today. And I'll rather be talking to the gynecologist when we refer patients, that these are these are your observations. Yeah, wonderful. Thank you. Dr.
Excellent talk, Dr. Raman. Appreciate all your time and efforts that you put in this program. So would you want to take up a question now?
Sure, let's do it.
So the question is that there are several case reports of unexpected vitamin deficiency, especially vitamin B12, after a bariatric surgery. And we know that vitamin is very important for a pregnant woman. So how should one tackle that problem, especially if the woman is breastfeeding the infant?
So, Dr. Unnati, this is not an unexpected problem. A very large percentage of population, even without bariatric surgery in India, has vitamin B12 deficiencies. Most of us will have, and especially people who live in a healthy environment, sanitized environment, the vitamin B12 deficiency is very common. So after bariatric surgery, all the patients are advised to receive B12 supplement on a regular basis. Now, only patients who are not complying with the requirement, B12 deficiencies are seen. We have, and in India, we have excellent sublingual vitamin B12 tablets, and we give them maybe once a week or twice a week, and that is enough. We don't have to give injectable vitamin B12 in India. This is more of a issue in Western countries where they have to give. And so I think this is a responsibility of the bariatric program and also the obstetrician, that during pregnancy, we ensure that they remain healthy, and a minimum amount. So now when we are giving a supplement, we are giving supplement of what is regularly required. We are not overdosing them. So I believe, and obviously Dr. Coelho can explain that better, that even during lactation, whatever is the RDA, that much B12 the woman can be supplemented, and we are not overdosing. So I don't foresee. And B12 doesn't have a toxic dose. B12 toxic dose is very high. So even if somebody is little bit overdosed, it doesn't really matter. Dr. Coelho, do you want to add on to the lactating woman here? I think you are muted.
Yeah, Dr. Goel, no, it is very important. And there are as you said, the sublingual B complex vitamins are very, very valuable to these patients, because as it is, they don't like to take so many medicines. Absorption is poor. So this is very good. And their diet also is not, they have to be very careful, have frequent small meals, etc., etc. That I think we inform all the patients. But sublingual vitamins are very good.
Thank you. I think both of you answered that question beautifully, and then rest of the queries I think were answered in the presentation. So Dr. Kiran, Dr. Raman, we have one of Dr. Raman's patient with us, Miss Megha. Miss Megha, could you please turn your video camera on? So Dr. Kiran, we invite these post-pediatric surgery patients every week so that they can share their experience live with the HCPs and with the audience, so that, you know, the doctors also get to know that how a person is doing post-pediatric surgery. Ms. Megha, are you there with us? Can you hear us? I think she's muted. Yeah, she's there. Hi, Miss Megha.
Hello. Yeah, I'm so sorry. Yeah.
No, that's okay. We can hear you, see you clearly. Can you see us? Can you hear us?
Yes, I can.
Okay. Hi, Miss Megha. It's a pleasure to have you here. And it takes a lot of guts to come and talk about your story, especially when it comes to health. So we have Dr. Kiran, who's a very famous obstetrician and gynecologist herself. And you know Dr. Raman, of course, he was your doctor. So I just have a couple of questions for you if you're okay with it.
Yeah, definitely.
Yeah. So would you like to tell us what health issues were you facing pre-bariatric surgery? What were the challenges that you had?
Pre-bariatric surgery, I basically got myself operated when I was 21. So back then I did not have any issues at all, but I rather got into the surgery as a preventative measure so that I don't get those complications at all to begin with. So I got operated in 2010, around 11, 12 years ago now. So yeah, and I haven't had any complications regarding obesity as such, because I have managed to maintain myself pretty well so far.
Good to know. I think that's a very bold step, knowing that you do not have a complication and you still took the decision of bariatric surgery. So what motivated you to go ahead and do the bariatric surgery?
The thing was that I had to go for bariatric surgery because my weight issues stemmed from the fact that I was given recovery steroids before I was 1 year old. To save my life. A long story, I won't get into that. So because of that, I used to have a lot of water retention. So the thing was, no matter how much I tried, right from my 7th standard, I remember going to gym, trying different diets and whatnot. Nothing medicinal or medical, but whatever I could to bring my weight to a certain level, but nothing seemed to work. And no, even it wasn't even a scene where my weight was chalo 80 kilos and it stayed that way. It wasn't like that. It always kept increasing and increasing and increasing. There was no limit to where my weight was going. So finally, when I was 121 kilos, when I was just 21 years old, we thought we should take a decision before it goes, extremely morbidly obese or something like that.
Wonderful. I think you have answered that wonderfully. So so it was 11 years before you got the surgery. So
Yeah.
Are you married now? Do you have a family?
I am separated now. Actually, I have a 4-year-old daughter.
Wow.
And, she is the healthiest child I've ever seen.
So I think since our topic today was regarding obesity and pregnancy, so would you like to share your journey, that post-obesity surgery? Did you have any complications during your pregnancy? How was it? How did the entire experience go?
Definitely. So, right when I got my surgery done, I was 21. So I had asked, as Dr. Goel said, patients come in with a lot of questions. I had even gone one step further to ask, will the staples in the surgery hurt my child? Will they poke me? Such. So I had gone into it, with all my eyes open, you can say. And then when during the pregnancy, first of all, there was no issue with conception whatsoever. And I had the most uncomplicated pregnancy that I've seen. I had nothing, as in I was living a very regular life. I had no cravings, I had no pains, I had no, I don't know what that thing is called. We have issues with the nerves in the legs. I forgot scoliosis, I don't know what the name was, but none of that, nothing, no backache, and my height is approximately 6 feet. So my stomach did not show till I was in my 8th month. I didn't even look pregnant. I used to take lectures. I'm a lecturer, so I used to take lectures on my feet for 8 hours a day till approximately 2 weeks before I delivered. And I asked the doctor whether this lifestyle is healthy for the child because I had not gained weight at all. I was around 72 kilos and I had hardly gained 5 kilos throughout the pregnancy. So I was a little worried. Is the child not growing well? Is it malnutrition? Is it whatever? Because having gone through health issues or, having seen that maybe I might have it, I was very nervous, you can say. But touchwood, even during the day the child was born, actually what happened was I delivered her 2 weeks before my due date. 3 weeks before my due date, I got a viral fever and I was in saline for a week. But till that day, the doctor had said that I was all set for a natural delivery. But because of the saline, the water in my stomach had reduced and it was causing pressure to the child, and I had to go through a cesarean. The child was 2.4 kilos and 2 weeks premature, but she was not declared as a premature child because she was extremely healthy, touchwood, extremely healthy. She cried on time and all her statistics were normal. So even though she was something 200-300 grams overweight according to their standards and 2 weeks before time, she was still declared as a naturally delivered child, and she wasn't premature. So it was a very beautiful pregnancy with no issues whatsoever.
Beautiful story, and I hope your child always remains healthy. You always remain healthy.
Thank
So I
you.
hope are you following your post bariatric surgery protocols till date?
Honestly speaking, for a couple of years in the middle, I had let it go. I had not exercised. I had not paid much attention to my diet. But honestly speaking, even when I did not pay attention, I still managed to maintain like a regular person would. When you have had like 4-5 parties in a month, you gain 2-3 kilos, and then when you're eating regular gharelu khana, then you come back to what you were. So I'm living a very normal life. Where I don't have to worry too much. Oh my God, if I eat this, how much will I gain? If I don't, what will happen? And that it's pretty relaxed.
Great to know that. Appreciate all your efforts. Congratulations for you that you
Thank you.
completed your surgery successfully and you had a healthy pregnancy. And appreciate all your efforts of coming out here. I'm sure your story is going to inspire a lot of people here. So, Dr. Kiran, Dr. Raman, anything for Miss Megha?
Dr. Coelho?
Yeah, Megha, wonderful story. And I think you managed to keep that weight off. You've had a beautiful pregnancy, a lovely this thing. So absolute success story of bariatric surgery. So important.
Absolutely.
I'm so happy.
Thank you so much, ma'am.
All thanks
I'm so
go to, I
excited
think,
to come and speak today. I was so happy.
I know. And a lot of thanks to Dr. Raman.
Definitely, because
Yeah.
I mean, the whole time, when people after a successful delivery, they thank God. Oh my God, it went well. I like, thank Dr. Goel, it went well. God was not
Really.
the first person on my mind.
So, Megha has she has maintained weight and she has delivered a beautiful baby. But, people don't realize one statement from her today may be giving hope to so many women across the country, because this program is watched by family physicians. And once they hear a story from a mother's directly from her, they will be able to convince their patients anywhere. They can get a surgery done in Delhi or Kolkata. That is not the issue. The issue is, at the end of the day, those women who are not getting the benefit of bariatric surgery in time, or they were scared because they thought that pregnancy might affect pregnancy. So she is like a role model for so many of the future women that even we will never know. But it's just so important. So thank you so much for joining in today. And
Thank you so
sharing your
much for inviting me.
And
Congratulations, Dr. Raman. Good, great work, Dr. Raman.
And congratulations to Meera. Ultimately, bariatric surgery is as successful as the patient makes it successful. So thank you so much. And thanks, Dr. Coelho, for being here on the program today. And,
Thank you for inviting me. I enjoyed the
my pleasure. Thank you so much. Dr. Unnati.
Thank you so much again, Dr. Kiran, Dr. Raman. Dr. Raman, I keep telling you, this is a great initiative, and this is currently one of my favorite academic programs. So I'm sure our viewers here are taking away a lot of insights. Miss Megha, your face, your radiance tells everything that how things have been for you. I would like to tell you all the best for your future journey. And to all our viewers out there, I hope you're gaining some valuable insights from this. And please stay tuned with us next Thursday. We will be back where we will discuss the next series, next program of obesity management. Thank you so much, everyone, for being here. Thank you, everyone.
Thank you.